Okay, good morning, everybody. We'll make a start, and thank you for joining us this morning to hear about this very important subject around Capgras. We're absolutely delighted to welcome Professor Iracema Leroi, who is an expert in Lewy body dementia and Capgras syndrome. We also welcome consultant Admiral Nurse Rachel Thompson. We would ask if you've got any questions during Professor Leroy's presentation, if you could put them in the Q&A, and then at the end of the session we will go through as many questions as possible. This session is being recorded and will be available on our YouTube channel in the next few days. So I'll hand over to you, Professor Leroi.
Super. Thank you very much for the invitation, Jackie. It's wonderful to be here, and thank you, Rachel, as well. So I'm going to present some slides for the next 25 minutes or so, and I hope you'll find them interesting. And after that, we can have a chat with Rachel and talk about things such as management of this condition. So let me just share my slides. How are we doing? Is that sharing? Okay. Yep, full screen. Okay, I think we're ready to go. Good. So, misidentifications in Lewy body disorders. So you'll see I haven't called it Capgras syndrome, I've called it misidentifications. And as the talk goes on, you'll see why I've chosen to call it that rather than Capra. The logo on the front here is Lewy Body Ireland. And I've put that there because this is a new third sector organisation that we've just developed or are in the process of developing in Ireland with the support of the Lewy Body Society in the UK with Jackie, and also the Lewy Body Association, Lewy Body Disorder Association of America. And this is to support people living with Lewy body and their families in Ireland. So just to put that out there, and we'll be launching our website for Lewy Body Ireland probably in the beginning of next year. So please let Jackie know if you're interested in coming to our launch and knowing more about Lewy Body Ireland. So first of all, who am I? Well, I'm a geriatric psychiatrist, and I've been working in Ireland for the past 2 years. Previous to that, I worked in the UK for 15 years, and before that in America and Canada. And my clinical work is at St. James Hospital here, where I've established a new mind and movement clinic within the memory service. And the reason is because Lewy body dementia or Lewy body disorders are not generally well recognized in Ireland. And in the brief time that I've been here, I've seen that many people are not being diagnosed. And as a result, they're not getting the support and care that they need. And so hopefully by centralizing things and developing a specific clinic, we can move forward with supporting people. And my academic affiliation is with Trinity College Dublin, specifically with the Global Brain Health Institute. And this is a picture of Trinity, and we have one of the most beautiful libraries in the world. So please, if you come to Dublin, come and visit Trinity and of course see the library. So, Lewy body disorders. Now on the call, you'll all be expert in this topic. And so of course you'll be aware that Lewy body disorders is considered the chameleon of neurodegenerative disorders, because Lewy body can present in so many different ways. So could present with motor problems, Parkinsonism, and end up in a neurology clinic. Could present with falls and blood pressure drops, and could end up in a frailty clinic or a falls clinic in geriatrics. Or in my case, I often see people who present for the first time with hallucinations and delusions, in other words, psychotic symptoms, and end up in psychiatry. Sometimes people end up presenting for the first time in accident and emergency because they're presenting with fairly acute onset of confusional states, looking like a delirium. So Lewy body can be challenging, and this is one of the reasons why it's very important to keep the discussion going and ensure that the health and social care ecosystem is aware of Lewy body and all its manifestations so that we can link up care. So why does it present in this manifold different ways? Well, as many of you will be aware, that the misfolded proteins or the Lewy bodies that are driving this disorder spread to different parts of the brain. So initially in the brainstem lower down, people present with symptoms like low blood pressure, falls, constipation, body temperature dysregulation. Also, we see problems in the olfactory lobe, or the olfactory bulb, in other words, difficulty with smells and perceptions of smells. As the Lewy body spread into the motor areas, this is where we start seeing Parkinsonism in a high proportion of people, but of course not everybody. And then when we get spread to the cortical areas, the thinking areas of the brain, this is where thinking, visual spatial functioning come into play. And through all of these different processes, we have problems with perceptions, such as hallucinations and delusions and misidentifications. So a complex condition at many levels. So I'm just going to start by drawing your attention to this very beautiful article, which was brought to my attention by my colleague Karen Meenan here in Ireland. And she's working on Lewy Body Ireland together with me. And it came out in the New Yorker in January of 2021. So it's a very new article. So I highly encourage all of you to dig it up on the web if you have some time, and perhaps Jackie can post it for us later. And it's an article written by this gentleman, John Mattis, about his wife who developed Lewy body. And he talked about living with a visionary. And he describes over the years the various symptoms that she had. And I'll just give you a few quotations here. So she described a difficult night because the man with no legs was lying beside me all night. He has been mumbling in pain and no one was helping him. She also talked about the flowering man. He's very nice. In other words, hallucination of an imaginary figure. That's not really a cat, is it? She would say as she looks at something. Talks about a dead baby. So all these kinds of perceptual abnormalities of different kinds, illusions, hallucinations, delusions, all blend together to create a visionary kind of system. So thinking about this idea of psychosis, hallucinations, delusions, illusions in neurodegenerative disorders, of which Lewy body is one of the most common, how do they present? Well, you'll all be aware, of course, that Lewy body can present with complex visual hallucinations in nearly 3/4 of people, again, from the occasional sorry, somebody's coming to my door, from the occasional visual hallucination, which people are very aware of what's happening, all the way to complex systems that people are unaware that they're abnormal. In other words, they've lost insight, as well as misidentifications of animals, people, or detailed three-dimensional objects. In contrast, in Alzheimer's disease, the system's a little bit different, and here people tend to present more with paranoid ideas, and misidentification is less common and very often associated with hallucinations as well. And then finally here, frontotemporal dementia, again, tends to be presenting slightly differently. Now, just briefly, what exactly are delusions? Now, with all of us, we have beliefs of various kinds, and they're all held with varying degrees of truth. Now, again, what is truth exactly? However, there are certain points at which beliefs are fixed and they're considered false by the majority of people in a community. In other words, they have to be community relevant or specific. And they're firmly held even when contrary evidence is presented. So a delusion is something that isn't really open to reason. Now, that is the strict definition. However, as in some cases, of course, particularly in Lewy body, delusions can wax and wane depending on the level of alertness that a person has. And that means that at times people can be convinced out of their false beliefs, whereas other times they'll be holding them with great conviction. And the kinds of delusions we see are accusations of theft. Somebody's moving my things, somebody's stealing my things. That tends to be a little bit more common in Alzheimer's disease and often associated, for example, with people misplacing things, forgetting where they are, and so on. What's fairly common in Parkinson's disease spectrum, a little bit less so on the Lewy body side, but particularly more on the Parkinson's side, is delusions of infidelity, or what's called the Othello syndrome. In other words, believing that your partner or spouse has been unfaithful to you. And this can be very distressing for both partners. And at times it leads to divorce or people attacking the partner, for example, and can lead to tremendous distress. Grandiose delusions are whereby people believe that they've got special powers, that they have particularly good at something, or they are Napoleon or Julius Caesar or the president or the prime minister, these kinds of things. That tends to occur more in affective or mood disorders. In other words, bipolar disorder, when a person is very high in their mood, called mania. And that can also occur in psychotic conditions like schizophrenia. And then finally, of course, misidentifications. And of course, these pictures are from the Othello play. So what I'm going to do now is just talk you through a little case study, a case study of Mr. Broadbean. And this, of course, is no patient in particular. It's a compendium of a number of different patients, and misidentifications are common. So, for example, a few weeks ago in my clinic, I had 3 patients in a row, or 3 families in a row, who were reporting misidentifications. So this is a combination of all of those. So Mr. Broadbean is a 74-year-old man with a long history of prostate problems, and as a result of that, he had multiple surgeries over the years. And very typically, when older people have surgery and have general anesthetic and are on painkillers, they may develop a confusional state or a delirium following the surgery. During these times, our patient developed a confusional state and also believes that his wife had been replaced by an identical looking bad wife. So we had the good wife who was the real one and the bad wife who was the evil one. And it was very distressing for him. And one of the reasons it was so distressing was because he didn't want to engage with the bad wife. And whenever she asked him to do things, or she gave him a meal or helped him with his care, he would reject that. And he would constantly ask for the good wife. However, this resolved after surgery, and he generally got better, no other symptoms. But over the years, gradually, this idea of the bad wife started to emerge spontaneously and more frequently. And the periods of the bad wife being in the house became longer and longer. So before it was just a few minutes, then it became a few hours. Sometimes it would last for much of the day, many days a week. So this gentleman eventually saw a psychiatrist and was diagnosed with a delusional disorder because there were no other symptoms, no movement symptoms, no orthostatic hypertension or blood pressure control problems or anything else, purely the delusional disorder. And he was treated with antipsychotics, which are dopamine blocking drugs. So they block dopamine in their brain in order to help this kind of condition. And antipsychotics are the mainstay treatment for primary psychotic disorders like schizophrenia. The problem, of course, as you will all be aware, dopamine is in short supply in conditions like Parkinson's disease or Lewy body. So if you give people a drug that blocks dopamine, of course, you could be getting into significant problems because you're pushing their dopamine even lower. And that's one of the difficulties, of course, when the Lewy body presents with psychosis without any other symptoms early on. People tend to get put on antipsychotics. However, gradually, cognitive symptoms started to emerge. He was having difficulty with visual spatial function, had difficulty putting things together, couldn't assemble a flat pack from IKEA anymore, started to become a bit more forgetful, less attentive, and he also developed a right-sided resting tremor. So the picture was emerging that this is more than a delusional disorder. He then went for a DAT scan, which is the typical diagnostic tool that's important in Lewy body. That came back positive, suggesting that yes, indeed, he had Lewy body dementia. And of course, then the diagnosis was changed and the treatment adjusted. So an example in this case of how a number of years before the onset of the other aspects of the Lewy body syndrome, here you have somebody presenting simply with the misidentifications. So depending on which case series you look at, misidentifications can occur in upwards of 70% of people or about 20%. So we'll settle on the conservative figure of about a fifth. And there are 2 main types based on the content of the delusion. One is the Capgras type, which includes the Fregoli syndrome, and I'll tell you what that's about in a minute. And the other is clonal pluralization. Now, these are terminologies that get bandied around and often misused and mixed up. And it's not important to get too caught up, other than the point that this is a spectrum of different presentations, depending on exactly where in the brain the pathology occurs. Let's start with Capgras. So for people on the call, you'll be probably very familiar with this idea of that this is somebody being, the perception that someone's been replaced by an imposter. And it's often the person most close to them, their primary carer, family member, like a spouse or a child, for example. And that imposter is generally identical looking. In other words, this idea that this is not my husband, even though it looks like my husband. Someone is acting like my husband. There's a stranger living in my house. But it's not unique to Lewy body. And we see it in people who have schizophrenia. We see it in the context of delirium, like our gentleman, Mr. Broadbean. We also see it in people who have psychotic depression. So of course, psychotic depression is whereby somebody has a depressed episode that is so severe that they start to develop perceptual abnormalities like hallucinations or misidentifications. But they're most common in neurodegenerative disorder like Lewy body. And sometimes it's so intense that it can lead to killing the imposter. So it's certainly not benign. And I think anyone on the call who's experienced living with misidentifications, either by themselves having it or being on the receiving end and being accused of being imposter, they will understand the intense distress and unhappiness that it can lead to. But Capra isn't unique to misidentifying people. It can also affect places, pets, inanimate objects, and so on. So where did the name come from? Capra. So this is Dr. Capra here. He was a French psychiatrist. And together with his colleague in 1923, they wrote a paper, a case study of Mademoiselle M. And this was a person, a young woman who presented with florid psychosis. And she believed that her husband, her children, and her neighbors had been replaced by doubles. And these doubles were replaced by doubles. So in some cases, it reduplicated so many times that there were 80 copies of her husband. Now, this isn't a typical case. And usually in DLB or Lewy body dementia, what we see is a single person being replaced by an imposter. But again, it can take different forms. What about Fregoli syndrome? So related but slightly different. And in Fregoli syndrome, we have the recurrent and transient belief that one or more familiar peoples or persons, usually persecutors, follow the person and masquerade as several other people. In other words, you'll see a crowd or you'll see people in the shopping center and they'll all be that person. In other words, there he is again, there he is again, there she is again. And you're recognizing a certain person in unfamiliar faces. And where the name comes from is this very famous actor from the 1930s called Fregoli. And he was a quick change artist and impersonator. And he was able to take on different disguises. And that led to the name, the Fregoli syndrome. So this tends not to affect people on the receiving end, but rather the person themselves becomes extremely distressed because they feel that they're being stalked or haunted by this face and this person who pops up everywhere. Other phenomena, and again, not to get bogged down by the terminology, but it's quite fun and interesting to look at these different descriptions. Intermetamorphosis. This is the belief that people around the person switch places, but they're not being in disguise. Reverse intermetamorphosis is the belief that a person has replaced the person with the symptoms, both physically and mentally. And that of course, can be extremely distressing. Then there's this phenomenon of clonal pluralization or reduplicative paramnesia. And this manifests as a misidentification of a reflection, or it can be that you are replicated or that others are replicated. So you're not necessarily misidentifying them or saying they're an imposter, but they are replicated. So what exactly are these Capra misidentifications if we pull it back to the most common form in Lewy body? Well, they can be considered a cognitive disorder, in other words, a complex memory type disorder of abnormal facial recognition. And as you can see here, when we talk about cognitive psychology, we think about language, memory, thinking, attention, perception. Or some call it a psychotic disorder, in other words, a delusion like we've been talked about, in other words, a fixed false belief. But again, this terminology and this confusion comes simply because different professionals in different disciplines have been looking at this problem from different perspectives. And ultimately, it all is the same thing. It's just described differently. And it's probably a combination of the two. So let's unpick this a little bit. What really is going wrong here? Ultimately, it's about a neuropsychological process that's a bit faulty. So the wiring in the brain has gone wrong, leading to the misperception of information. So this is because the brain receives distorted sensory information, in other words, the face in front of you, and that interferes with the accurate interpretation of the world. And that's because it lacks the neural circuitry, in other words, the brain wiring, to distinguish whether the information is received as true or as false. And it leads to this mix-up and this misperception. So in order for this to happen, there isn't one simple place in the brain that is abnormal. It involves different systems, partly the visual processing system, in other words, understanding what you're seeing and perceiving, but also how you perceive that and how you monitor your ideas and understand what is true and what is false. So you need both of these ingredients together to result in a misidentification. So for those of you who are interested in digging more into this topic, a very nice paper, quite a classic paper already, a number of years old, but I think it put out some interesting theories initially. It's this paper by Hollis and Lewis called the Capra delusion, a window on facial recognition. And what was very interesting here is that they tried to understand Capra in the context of a slightly different condition called prosopagnosia. Now, prosopagnosia is a disorder in which people cannot recognize faces. So your visual recognition of faces is faulty. Some people have that their entire lives. Other people develop it in the context of a neurodegenerative disorder, like Alzheimer's disease, for example, or Lewy body dementia. And what happens in prosopagnosia, according to this paper, is that people are unable to overtly recognize a face. However, some levels of recognition are still there. In other words, there's covert recognition. But Capra is the mirror image of that. In other words, you recognize the face. Oh yes, that's a familiar face. That's my husband or that's my wife. But that unconscious covert recognition is faulty. Hang on a minute, that's my wife or my husband and it looks exactly like them, but I'm not quite getting the right vibes that it really is and something's wrong. In other words, my unconscious automatic recognition of who they are is broken. And therefore, the only way I can understand this or interpret this is that it's not really them. In other words, somebody's an imposter, looks like them but isn't quite, leading to tremendous distress and confusion and a sense of loneliness. One of my patients talked about being incredibly lonely, even though she was with her daughter all the time. And that was because it wasn't the right daughter that she was with, it was the bad daughter. And this was terribly sad. Sad for both parties, because of course for the daughter herself, she was doing her best for her mother, always being there, supporting her, looking after her. But she wasn't really there and being recognized for that. Okay, so a little bit of brain stuff again. Multiple parts of the brain are important here. And one of the key areas is this place called the fusiform gyrus, which is, you can see here at the base of the brain. So this is if you turn the brain upside down, you can see this area here at the base in green. And that's very important for facial recognition. If this part is damaged, and again, some people are born this way, you'll have tremendous difficulty in understanding familiar faces and recognizing them. But this part of the brain sends information to two areas, the temporal lobe, which is very important in memory, and also an area called the retrosplenial cortex, which allows comparison of that face that you see with those that you have stored in your filing cabinet, of which we've got many hundreds, if not thousands, depending on who you are. And people who have tremendous ability to recognize faces, like gifted politicians, will have that filing cabinet full of people and be very quickly to place the face. But when that goes wrong, of course, you run into difficulties. And this retrosplenial cortex is very important in encoding this familiarity, and it's also associated with emotion. It describes emotion. This is a face that's threatening. This is a face that's not threatening. In other words, this is somebody I care for. This is somebody I don't care for. And the role is very much what we call an evaluative role. It's making judgments all the time, rather than an executive role, which is about planning, for example. And then again, it's not just this visual system, but linked also to our belief evaluation in the frontal area of the brain, around about here. So I'm going to leave it there. So that'll give us some time to answer some questions and talk about some things and perhaps share some clinical scenarios. And Rachel will join us in this discussion. So just escape and get rid of, stop my share. There we go. So.
That was so interesting, and I know that I learned a lot, and I'm sure even you did, Rachel, from all that amazing information. So thank you on behalf of everybody that's on the call. Please, everybody, if you have questions, could you put them in the Q&A box, and we will start to work through them. So I'll kick off with a question. What do you think is the reason for the kind of lack of understanding or lack of awareness of this particular type of syndromes?
I'll make a comment and then I'll pass on to you, Rachel. That's very interesting. I find in clinic that people don't spontaneously report it. I have to ask for it. Now, why is that? I'm not sure. Because it's so unusual. It's frightening. People can't make sense of it. And sometimes it takes them a while to realize it's even happening. Because very often a person may hide the fact that they're misidentifying the person. They'll stop interacting with their loved one, become suspicious, but the care partner or the spouse may not recognize the reason for it. So it's a combination of those things. And so I think it's extremely important for clinicians to ask specifically about this so that it can open up the discussion, and it very often does. Rachel, what are your thoughts?
I was going to say something very similar, actually, Ira. So I think, as you say, people either feel reluctant to talk about it because there's a lot of, you mentioned about the fluctuations earlier as well, that I think when there are fluctuations, which we see commonly, don't we, is that there's a kind of a watch and wait kind of people, family, caregivers may notice something quite odd, or the person themselves may notice something quite odd and may want to just kind of put it to one side and hope that maybe it'll resolve itself, it'll go away. And there's probably, I think there's often a little bit of fear attached, is that, you know, why is this happening? You know, I as you say, it's frightening, I don't understand it. So there's a reluctance to talk about it. And I think particularly when it's a partner who's a spouse, that's when that's very difficult, because that relationship is so fundamental, isn't it, to, for some people, around the support that they have, that the level of trust. And often if people are assessed in clinics, for example, it might be that their spouse is with them, so you know, then it becomes very difficult for them to talk about that. I think the last thing I would just say is it depends where the person gets referred to as well. You know, it's so if they go through neurology, it may be that neurologists are not picking that up as much. It might be in psychiatry, as you say, sometimes the focus can be on the cognitive, the thinking and the memory, as opposed to the perhaps the more kind of hallucinations and delusional sorts. And if the person's kind of seen by a GP, GPs often don't have time to explore things in detail. So it's multifaceted, Jackie, but it's I think, you know, it's great that sessions like this are happening, because we need to be talking about it more.
I think we absolutely do, Rachel. Just looking at some questions that we have now. Jules has asked, can you get a DAT scan from your doctors?
Sorry, I'm not sure I understand the question. Yeah, DAT scans will, they generally are referred by doctors, yeah. So it depends where you are in terms of the provision. In Ireland, we get them, but we might have to wait a year. But they can also be done privately in the NHS. Yes, most trusts will pay them. Sometimes only neurology can order them. So if you're in a psychiatry department, you have to refer to a neurologist, and that can be a challenge. But the technology is broadly available, it's been around for many years. Does that answer the question?
I think so, yes, definitely. Nicholas asked, do you correct your loved one and say that they are not an imposter?
That's very interesting. Rachel, you start and then I'll jump in.
Oh gosh, this is always one of those, it depends. Because I think, and Ira, you kind of mentioned it earlier about the level of insight that people have. What I often start off with is trying to work out how fixed this belief is. If it feels like it's very fixed, then I would tend not to correct them, because I think sometimes what happens is then you can get into an area of conflict, and then the person's going to trust you even less. I think sometimes you can kind of, as I say, creatively kind of dance around it. So trying to perhaps think about, are there cues that help that person recognize and believe and trust who you are? It might be that just kind of questioning a little bit, and so I think the thing is not to confront or challenge, but just to try and express I understand that must be quite frightening. You know, what can I do that will help you? I think that's generally my response. I don't know, Ira, if you would add anything to that.
I think that's absolutely right. And people always think there's a right way and a wrong way, but there isn't. And even if you figure out the right way, it won't last, because tomorrow it'll be different. So it's always a moving target. And I think understanding that can also be helpful for care partners to recognize that they've always got to be problem solving and on their toes, which adds to the challenge. I think trying to understand that there is a partial recognition going on is helpful, because then your job is to try to appeal to the bit that's broken. In other words, yes, you recognize my face. What other bits can I help you to recognize? Whether it's familiar smells, familiar clothes, sounds, voice, maybe even singing songs from years ago. Trying everything in a gentle, non-confrontative way to try to trigger that recognition. And an example is whereby sometimes people don't recognize their own homes and their surroundings, and they get very agitated saying they need to go out, they need to go home. So families do that exactly. Let's go out the front door, let's walk around the block, let's get in the car, drive around the block, and then come back home. And that sometimes triggers people back into their presence and they recognize their own home. So it can be the same kind of tactic you can try, which doesn't always work. In other words, go out, come back in, maybe even wear some familiar clothes, perhaps even bring some old photos, again, in a non-confrontative way. And then ultimately it's about time, because very often these are transient. And family members will be very attuned to when is the right time or the wrong time. In other words, a good day and a bad day. And sometimes it's even hard to articulate what those are, but family members will absolutely know.
Okay, thank you for that really good advice, which I think we've just answered. Michael's question was around tips for helping with those situations. So Tracy says, Dad has an incredible memory. When we're using the sporting memory cards, like for past footballers, he can recognise and name them in seconds. However, he will ask that the lady in the house that we call Mum or Annette, as we try to use Mum's name more often, to help is not his Annette. And I'm not sure what area of diagnosis on what you have spoken about does Dad fall into.
That's fascinating, isn't it? So actually, I think here you're kind of seeing the difference between this idea of prosopagnosia and more of a misidentification. So the overt recognition is intact. In other words, these footballers, you know, your connection with them is the statistics on a card or whatever, however footballers recognize them. It's out of my domain of expertise. In other words, there isn't a very strong, complex recognition going on here. It's a face, and that is basically intact. So there isn't a prosopagnosia. However, with people who are close to you, your level of recognition is far, far deeper. And you've got that unconscious understanding of who this people is, how they move, how they smell, all these sorts of things that you're not aware of. And that's where it's faulty. So I think it's a slightly different process going on here. So I think we are talking here about a misidentification.
You're on mute, Jackie.
So Linda says, my husband sometimes has 3 of me. One can be the bad one, the other can be young, or another one is old, that is actually me. And sometimes one is male but looks like me. And I think possibly the bad one is if I've asked him to do something that he doesn't want to do, or have been annoyed with him. Are there anything particular that can make this worse?
Right, me or you, Rachel?
I'll start if you like, and I'll hand over to you, Ira. So I've heard family caregivers, particularly spouses, talk about this type of situation quite a lot, where when the person is upset with somebody, so perhaps as a carer, you've got frustrated, and we show our frustration sometimes on our face as well as what we say, don't we? And without realizing it, our non-verbals can be very powerful. So when we're showing frustration, or in fact, as Linda said here, that you've asked them to do something that perhaps they either are struggling to do or that they just don't want to, then that frustration can kind of, it can make the Capgras become even more difficult. And so what often I found, again, it's just based on speaking to family caregivers, that they say there's the bad person and the good person. And the one when, you know, we're getting on really well, it tends to be okay. And when they're upset with me, I become the bad person. And I think that I've found just from listening to other people is saying, actually, if that happens, just sometimes kind of removing yourself from the situation. So, you know, perhaps going out and seeing if that kind of triggers a different response, if that distraction has changed that way that person is kind of seeing you. That's what I would suggest. Ira, have you got any other good tips or clues? Or
I think that's probably right. Keep in mind that so much of this is tied up with think about the brain, specifically emotional pathways. And so again, when you're tapping into emotions, exactly as Rachel said, because you're asking somebody to do something that they cannot do and they feel anxious or they don't want to do, or they feel put upon, it triggers certain negative emotional memories that then get associated with the bad rather than the good. Now, we can't be happy and all the time, so it's a complex thing, but trying to keep the stress and the emotion out of it and stepping back and, again, coming in a different context can be helpful. And, you know, that's a big ask when things are tense or things need to get done or time is short and you've got to get out the door to an appointment. It's difficult to have these kinds of rational approaches to the problem. But that's sometimes the best way to deal with things.
Thank you. We have questions around scans. Is a DAT scan the same as a PET scan?
A DAT scan is not, well, it's similar to a PET scan in the sense that you've got two broad categories of scans. You've got those that look at the structure of the brain, like an MRI or a CAT scan, and the structure can look perfectly normal, but it says nothing about how it functions. And then you've got functional scans, which about how basically the brain functions, and that can be done through blood flow or, you know, glucose metabolism in the brain, and there's different ways of doing it. So a DAT scan is actually similar to a PET scan, but it's actually a SPECT scan with a particular kind of dye. And what happens is the person gets the dye and they get injected into their bodies for about 30 minutes, and it gets taken up into the key areas of the brain or not, depending on whether those areas of the brain are intact. And then we look at it and we can see, yes, the uptake, sorry, the uptake is intact or it's not. And that can give us a sense of whether this looks like a picture that's consistent with Lewy body or not.
Thank you. Somebody has asked, my husband thought there were 4 of me about a year ago, but that seems to have gone. Can Capgras come and go?
The answer is yes. All symptoms in Lewy body can come and go. Another example of this is sleep disturbance, REM sleep behavior disorder. Some people have this years before the onset of other aspects of Lewy body, and then it disappears, or it can come back. And likewise with hallucinations and delusions of different kinds, they will fluctuate, and that depends on so many different aspects. Sometimes they respond to treatment. So people who live with Lewy body get often treated with what we call the memory enhancing drugs, which is a misnomer because they do more than enhance memory. But in other words, the cognitive enhancers like rivastigmine or donepezil, and these drugs affect a chemical in the brain called acetylcholine, which is very important in Lewy body. And that can sometimes be helpful with the fluctuations in the brain that sometimes drive these perceptions and also the perceptions themselves. So when treatment starts, sometimes these problems go away, but not always.
Thank you. So Jane's asked, could this syndrome explain why my dad often ignores me and won't speak to me, but at other times he's very chatty? What can I do when he ignores me to get him engaged?
Rachel?
So I guess, yes, that is possible. The possible reason, if somebody's not trusting you or not quite sure who you are, your instinct, I think for all of us, if we're in a situation where we feel anxious or we're not quite sure, sometimes we do withdraw. So that might be what your dad is doing. I guess in order to try and engage him is that just kind of thinking, actually, maybe, yes, of course, we want to keep people engaged and active, but maybe it's okay not to overstimulate people at times. If they're getting frustrated, I think, you know, we'll see that. I think if you're really worried that somebody's getting withdrawn, then tapping into things that you know they can do still, or things that provide them comfort. And sometimes we have to adjust activities. So for example, if somebody used to really like a particular, doing crosswords, for example, I'm just pulling that out of my head really, but it might be that doing crosswords is too difficult now and may cause frustration. So try something that's engaging in a different sense. So if the sense in this instance can be around the kind of visual processing and finding it difficult, then perhaps using music, for example, that may provide a different kind of stimulus, and then gradually perhaps using that as a tool to kind of perhaps reminisce, or something that will just take that person away from their kind of their worried thoughts, really. It's in the same way that, you know, we would advise somebody who's kind of very anxious about something and worrying constantly, is trying to find things that move you away from getting stuck in that. And so that's just tapping into things that your dad still can do, things that are kind of fairly simple, and that will be pleasant and not too stressful. I think that's what I would suggest. Yeah.
Thank you, Rachel. Okay, so we have a question from Michelle, which I'll try to summarise. So Michelle was dealing with the holiday details this morning, and her husband was getting anxious because he thought that there was more than 2 of them going on holiday, that there was a lot of people. And when he went out to have a walk, she didn't know how to deal with it, but when he came back from his walk, he was okay. So I think Michelle's just saying that she's kind of experienced this firsthand this morning. So hopefully some of the advice that you as our experts this morning have given will help Michelle going forward to deal with these scenarios. Tracy's asked about asking future questions. So what I would say, I'll take this question. What I would say on this, Tracy, is maybe if you check out our social media sites, once a month we have a tea time with Lewy, which Professor Leroi and other experts join. So there's always that scenario where you can ask questions. We will have more suggestions coming up, and we have also the Dementia UK helpline, who we partner with Dementia UK. So you can always ring the Admiral Nurse helpline and get first-hand advice on those. And if you say that you've been referred by the Lewy Body Society, because we pay the Admiral Nurse helpline to take those calls for us. So I hope that helps to kind of answer your question.
Can I just add there, Jackie? I think a lot of people have really struggled over, particularly over the last year and a half with the lockdown. And we hear on our helpline and, you know, through various channels that people are really struggling. So Tracy, you know, that does sound really difficult, that you feel kind of that you've been left to manage things. I often say to people, if they feel like there's a change or they're worried about medication and that needing to be reviewed, then, you know, actually sometimes you're having to go back to the GP and getting them to try and chase referrals, either back to the memory service or to the neurology department, whoever is overseeing somebody's care. But you know, I think that regular reviews of medication are really important, because things can change quite a lot, and you do have to be, certainly as family members, you have to chase a little bit. So yeah, I just wanted to say, I know it's really tough.
No, I think that's so important, Rachel. Thank you. And somebody's just said that it's interesting, you say, to take the emotion out, to step away. But obviously being in that scenario is very difficult. Any more suggestions about bringing them back into the moment, bringing the person back into the moment?
I think that's a very important point. And again, there isn't one right way to manage a situation. Sometimes stepping away will help so that things don't escalate, or the presence of the person who is the bad one causes more distress. Sometimes the opposite, in other words, gentle reassurance, talking about, this is where, hi mom, this is me, it's Tuesday today, this is where we are, we're going off to wherever, the shopping center, this is all fine, and trying to bring in as many familiar things as possible. That can be helpful. So ultimately it comes down to sort of the expert dyad, the person with a condition and their care partner, figuring it out hopefully with support, because there isn't one thing that fits every scenario or every situation.
Okay, so Jules has said, my dad has been diagnosed with Alzheimer's, but I believe he has Lewy body dementia. How do I get my suspicions confirmed? And I'm sure this is a story we've heard so many times.
Yeah. And Jules, you're the person who asked about the DAT scan, didn't you? So that's why you're asking, isn't it? So yes. So if your dad has been diagnosed with Alzheimer's disease, I assume that this is in a memory clinic. If not, it should ideally be so. And it's about asking the memory clinic doctors to order a DAT scan, because a DAT scan is licensed to determine whether it's Alzheimer's disease or Lewy body dementia. Another way to approach this, and hopefully with your memory doctors, even your GP, is that you can draw their attention to the Diamond Lewy toolkit. Maybe we can pop that in the chat, Jackie. A very basic checklist of Lewy body symptoms. And if you read through them, you'll understand them, and you can, don't be shy about giving it to your GP or memory doctor, saying, hang on a minute, this looks pretty familiar. We're ticking all these boxes. Can we have a chat about this? Because as you say, Jackie, this is extremely common. And it's important that people get a proper diagnosis. Yeah,
it is. And I think what we'll do on our social media channels is we'll put a link out about that. And everybody who's registered for today's session, we can also send them a link to the Diamond Lewy stuff as well. So I think, yeah, that's really important. A really useful piece of suggested advice from Karen, who says, my mother had Alzheimer's, but towards the end, she only recognised me if I wore a particular jumper or a necklace. And I think that's so true, Karen, that I think that would work potentially for any form of dementia, whether it's Lewy body or any form of dementia, and anything like that is always worth a try.
And you don't know what it is that's going to be helpful. Again, smells can be really helpful. So, if there's a perfume that a person used 20 years ago, go back and use that perfume. That may be helpful. Or again, sing songs from years ago, or play music from a different era. All of these things can just help orient a person to the familiar, because those are the things that they're struggling with. So I think that's really nice advice.
Yeah, so I think that we've covered most of the questions. Any final comments? We'll start with you first, Rachel. Any final comments?
I think something that I kind of mentioned when we were doing the webinar on hallucinations is that sometimes you have to be a little bit like a detective, and that's very hard when it's a member of your family and you're in a stressful situation. But I think trying to step back, trying to remove your feelings of stress as much as you possibly can, sharing some of the care where you can, so you're having breaks, is really important. And then thinking about, are there particular situations or triggers that make things better or worse? Different times of day, just being aware of those things and thinking about trying different responses. I think, as Ira said, sometimes you can think, oh gosh, that works, and then you try it the next day and it doesn't. But it's almost like you need a kind of little toolkit of different responses that you can try. I just wanted to mention about safety. because I think, Ira, you mentioned that really crucial point of actually if somebody is really fixed in their belief and they're very scared as a result, then obviously if you are with that person, you've tried everything else, ultimately keeping yourself safe, and seek help. You know, don't try and feel that you have to manage this by yourself. And there was one, oh yes, the last point I wanted to say was just to add on to what Ira was saying about comfort. I often quote, I don't know if people are familiar with Maslow's hierarchy of needs. Psychologists talked a long, back in the 50s about actually we all have a fundamental need for comfort and a sense of belonging. And so when people have conditions that unsettle things like Lewy body or other types of dementia, that actually tapping into those things that provide comfort and help people feel safe are really helpful. So just trying to be creative about what will help that person. That was my last thought, really.
Rachel, would you suggest that if people or family caregivers are able to keep maybe a diary or things that kind of have worked so that they can refer back to it? So, because sometimes I think when you write things down and it gets it out of your head, and do you think that people may benefit from keeping some form of diary or journal?
Yeah, no, it's really helpful. So there's a kind of a manualized intervention approach, which is called the START program, that some people may be familiar with, and that encourages you to actually just make a note of things, because in the heat of the moment we're not often aware of what we said, what we did, how we behaved. So just keeping a record of that can just help you stand back and go, oh, actually I did do that and I didn't mean to. So next time that situation arises, you can try something different. But yeah, keeping a diary is, when you can, not really.
When you can, yeah.
Absolutely.
Yeah. Ira?
Yeah, I would agree with the diary, because it's the other thing is you bring it into your clinical team and you can share the experiences, particularly when things are difficult. Sometimes the entire focus is on what's happened for the last half hour before the appointment or the days before the appointment. But actually the month before, things have been going a lot better, or the reverse scenario. So having that diary just puts everything in perspective, so that can be helpful. The other thing I just wanted to say, I think Franz put a really nice comment at the end here, talking about even if the loved one isn't recognized, it's about exactly as you said, Rachel, just recognizing that this person needs security and comfort and asking them, is there anything I can do? Yes, I might not be the right person, I might be the bad one, but it's okay, I'm on your side, and let me know what's bothering you, and becoming an ally. So I think that's a really nice sentiment.
Okay, so thank you very much to our expert panel today. Thank you very much for everybody that took the time out on this sunny day, which I hope it's sunny where you are, and taking the time to join us. I hope you find it very beneficial. If you want to play back anything or watch this again, it will be available on our YouTube channel within the next few days. So thank you very much, everybody.